Good morning. I am S.Geetha, Department of Child and Nursing from Respiratory College. Today, I am going to take about respiratory distress syndrome in newborn babies. Let us see the introduction first. Respiratory distress syndrome of newborn, previously called IMNI disease. This is a syndrome in premature infants caused by developmental insufficiency of surfactant production and structural immaturity of the lungs. Respiratory distress syndrome is the leading cause of death in preterm infants. RDS, also known as neonatal respiratory distress syndrome, infant respiratory distress syndrome, surfactant deficiency lung disease. So, because of less surfactant production in the lung and also the structural immaturity of the lungs will cause the respiratory distress syndrome in newborn babies. Now we will see the anatomy of the lung first, so that we can easily understand the disease condition. Lungs are the major organs in the respiratory system. It is divided into two sections, right lung and left lung. Right lung has three lobes, which is slightly larger and heavier than the left lung. Left lung has two lobes. Lungs are covered by productive membrane called flora. With each inhalation, air is pulled through the trachea and causing the branches of the blood vessels. It's called bronchi. The end of the bronchi, alveoli will be formed. At the end of the bronchi, alveoli will be formed by, it will be formed like thousands of tiny air sacs. So it will be resembles like bunches of grapes. It will be surrounded by small blood vessels called capillaries. In the alveoli, type 2 epithelial cells will be produced the surfactant. Surfactant is a liquid made by the alveolar space. So it's as soon as the baby is born, it makes the baby to breathe in the air. So pulmonary surfactant is a complex mixture of phospholipids and proteins that creates a cohesive surface layer over the alveoli, in which it reduces the surface tension and maintains the alveolar stability, therefore preventing atelectasis. So, main function of surfactant is to reduce the surface tension. So, if it is not surface tension is not reduced, alveoli will get collapsed. Surfactant is a foamy substance that keeps lungs fully expanded so that newborns can breathe in air once they are born. When there is not enough surfactant, then alveoli collapse which each has. As the alveoli collapse, damaged cells collect in the airbase. They further affect breathing. The baby has to work harder and harder to breathe, trying to reinflate the collapsed airways. So, because of less surfactant production, it increases the alveolar surface tension. Because of that, the alveoli will be getting collapsed. Because of that, the RDS will be formulated in the respiratory syndrome, distress syndrome babies. This is the picture of deficiency of surfactant in the pulmonary alveoli. The first one is a normal alveoli. The second one is the collapsed alveoli. Coming to the definition of respiratory distress syndrome, hyaline membrane disease is a disease manifesting 6 hours of birth being related to deficiency of surfactant in the alveoli, leading to acute respiratory distress with fatal termination if not treated promptly. So within 6 hours of birth, we have to administer the surfactant so that we can able to reduce the neonatal mortality rate. Coming to the incidence of respiratory distress syndrome, the first one, Increase in incidence with decreasing gestational age. The baby born before 20 weeks of gestation will be having 60 to 80 percentage of risk for preterm delivery, and also they will be getting RDS syndrome. The baby born in between 32 to 34 weeks of gestation, they will be having risk of 50 to 30 percentage. The baby born within the baby born in the 37 weeks of gestation, they will be having only 5% risk of RDS. And also infants of diabetic mother also will be having 5 to 6 times higher than the non-diabetic mother. Coming to causes of respiratory distress syndrome, the first one is deficiency of surfactant in the pulmonary alveoli. So RDS occurs when there is not enough surfactant in the lungs. RDS will occur. Next one is contributing factors or any factors that decreases the surfactant, such as if the baby is born as a boy baby, the baby has sibling born with RDS, the baby has history of sibling, and also C-section delivery, especially without labor, because going to normal labor helps to become ready to breathe air for the babies. In case of in the C-section delivery, it is not possible. So it is also one of the cause for RDS. And also the condition of prenatal asphyxia, the baby does not get enough oxygen just before, during, or after birth. So it's also one of the cause for RDS. The next one is the baby has trouble maintaining body temperature. Child has hypothermia. Child is prone to get hypothermia. Child is full stress. Also the one of the reason for RDS. And if child has any infection, the baby is twin or other multiple babies, because usually twin or multiple babies will be known as preterm only. So in preterm delivery, surfactant will not be in the preterm baby's lungs. The surfactant will be formed properly. Because of less surfactant production, baby is getting the RDS. The next one is if the mother is diabetic, because too much of insulin in this baby body can delay the surfactant production. So these are the causes for RDS syndrome. Coming to the pathophysiology of respiratory distress syndrome, RDS occurs when there is not enough surfactant in the lungs. Surfactant is a liquid made by the lungs that keeps the airway, that is alveoli, open. This liquid makes it possible for babies to breathe in air after delivery. An unborn baby starts to make surfactant at about 26 weeks of pregnancy. Usually, the unborn baby will start to make surfactant at about the 26 weeks of pregnancy only. If your baby is premature, born before 37 weeks of pregnancy, she may not get enough surfactant. So, when there is not enough surfactant, what will happen? That tiny alveoli collapse with each breath. As the alveoli collapse, the damaged cells collect in the airways. So it further affects the breathing. So what will happen? The baby has to work harder to take breath and trying to reflect the collapsed airways. As the baby lung function gets worse, the baby takes in less oxygen. More carbon dioxide builds up in the blood. So this leads to increased acid in the blood, called acidosis. In case of an acidosis, the pH level will be low. Usually the normal pH level will be 7.35 to 7.45, and carbon dioxide levels will be increased and acid level will be increased. So because of less surfactant production in the alveoli, child cannot take a oxygen properly. So that acid levels will be increased, carbon dioxide levels will be increased, and pH level will be low. So acidosis will be found. Now we'll see the schematic presentation of RDS. Because of prematurity, because of preterm baby, the preterm baby will be having the immature lung. Because of that, surfactant synthesis, storage and release will be reduced. When the surfactant synthesis, storage and the release is reduced, automatically surfactant production will be decreased. Because of surfactant production is decreased, it will increase the alveolar surface tension. So the main function of the surfactant is it decreases the alveolar surface tension. So because of less surfactant production, the alveolar surface tension will be increased. So atelectasis will be formed. Atelectasis is collapse of the alveoli. So the alveoli gets collapsed, hypoventilation will be formed. In the lung cells, the lung cells will not get enough air. So hypoventilation will be formed. Because of that, child will not get enough oxygen in the lung space, in the alveolar space. So CO2 retention will be happening. The CO2 levels will be increased in the alveolar space. So it will makes the baby to it will increase the acidosis level. So because of that acidosis, pulmonary vasoconstriction will be formed. So it will lead to the pulmonary hypoperfusion. Pulmonary hypoperfusion is decreased blood supply will be in the alveolar space. So when there is a decreased blood supply in the alveolar space, it will damage the epithelial and endothelial cells. So because of damaging the epithelial and endothelial cells, it will make the RDS syndrome, that is hyaline membrane disease. Next, we'll see about clinical manifestation of respiratory distress syndrome. First one is tachypnea. Child will have increased respiratory rate. Usually, the respiration goes above 60 beats per minute. Next, child will have intercostal retraction. During retraction, the skin is pulled in between the ribs. So, you can be able to see the intercostal retraction in the preterm babies. Prognosis. Child will have bluish discoloration of the skin. Usually, the bluish discoloration will be seen in the nose, around the eyes, in the lips. Sometimes full body also, all over the body, we can able to see the cyanosis. Next is nasal flaring. Widening of the nostrils will be seen in the respiratory distress syndrome babies. While they are taking each breath, widening of the nostrils will be seen. Apart from this, child will have decreased muscle tone, body temperature will drop, child will have absent bowel sounds, child will have decreased urine output, child will go for hypotension, and child will have diminished breath sounds. So these are the clinical features will be seen in the respiratory distress syndrome babies. Coming to the diagnostic evaluation, the first and foremost is history collection. First one is an antenatal history. In the antenatal history, should ask for previous history of abortion. The mother has delivered any RDS baby. If it's a primary mother, we have to ask for mother is exposure to any radiation or exposure to any infection. So all the relevant history should be asked in the antenatal mothers. In the birth history, the main is Apgar score. Apgar score of the baby should be asked, and birth weight of the baby, and also baby is a full term or preterm baby. Everything should be asked. Coming to the physical examination, head to toe assessment should be done first. The next is we have to do the chest auscultation. During chest auscultation, a huge sound will be heard. And also, child will be having forced breathing in the uh, auscultation. Child, we can able to hear the forced breathing, forced breathing. In chest X-ray, we can able to see the atelectasis. In bronchogram, air-filled bronchogram, we can able to see. So apart from this, we have to do the complete blood count for the babies. PCO2 level will be elevated. So normal carbon dioxide level in the alveoli is 35 to 45 mmHg. It goes above 50. Levels will be elevated. Child will more prone to get RDS, and pH level will be low. So pH normal level is 7.35 to 7.45, and child will have low calcium level. The normal one is 7.5 to 8.5 mg per deciliter, and the portion pressure of arterial axis will be low. The normal level is 50 to 80 mmHg. Next, we'll see about management of respiratory distress syndrome. So, the management is divided into 3 stages: mild respiratory distress syndrome, moderate respiratory distress syndrome, severe respiratory distress syndrome. So, according to the stages, we have to provide proper treatment to the respiratory syndrome babies. The first one is a mild respiratory distress syndrome. Babies with audience need extra oxygen to stay big. It may be given in several ways. So, through nasal cannula, oxygen can be delivered to the babies. A small tube with prongs is placed in the nostril. Through the child will be getting the enough oxygen. Next is CPAP, continuous positive airway pressure. So, in case of a moderate distress syndrome babies, through CPAP, the oxygen can be delivered. This is a machine that gently pushes air or oxygen into the lungs to keep the air sacs open. It's the picture of baby with CPAP. When PCO2 cannot be maintained above mmHg, CPAP can be administered. Baby will be in CPAP. CPAP helps to keep the alveoli open and prevent their collapse during respirations. And also, CPAP improves the functional residual capacity. It improves the ventilation, perfusion, matching. The third stage is severe respiratory distress syndrome. Ventilated for severe distress syndrome babies. This is a machine that helps the infant breathe. When she cannot able to breathe well enough without air, a breathing tube is put down the infant's windpipe. This is called intubation. The infant is then placed on the ventilator to help him to breathe. For severe distress syndrome babies, the baby will be immediately intubated. So, through endotracheal tube, the surfactant will be administered. This is the different size of endotracheal tube. Usually for preterm babies, 2 to 2.5 centimeter tubes will be inserted. This is the picture of baby in endotracheal tube, and also baby will be in ventilator. Management of surfactant therapy. Usually, surfactant will be administered to the babies. It will be administered through the trachea. The advent of surfactant therapy has reduced the mortality rate from RDS syndrome by approximately 50%. Recommended dose of surfactant is 50 to 200 200 mg per kg. Usually 4 ml per kg body weight they will be given. The most neurotic is 2 doses. However, as many as 4 doses can be given to the child. When you are giving the surfactant therapy to the child, it should be interval of 6 hours to 12 hours will be there. It is the medical administration of exogenous surfactant. Surfactant used in this manner are typically instilled directly into the trachea. So, through the trachea, surfactant can be administered slowly. Usually, surfactant is administered intratracheally through a catheter passed through the endotracheal tube. So, after giving surfactant, we have to watch for the saturation and the heart rate in the ventilator at least for 30 seconds. So, after giving surfactant, we have to carefully watch the babies. Complication of surfactant therapy. If you are giving surfactant, then there will be a blockage of tube and child will go for bradycardia, child will have hypoxemia and child will get pulmonary hemorrhage. It's a picture of baby in mechanical ventilation. Your child has persistent apnea. Your child has oxygen saturation less than 90%. PCO2 60 mmHg are more rapidly rising means a child will be intubated through endotracheal tube. Surfactant can be administered. Child will be monitored in the ventilator. Apart from this, we have to maintain the child normal body temperature, and also we have to give proper nutrition to the child. Intravenous catheter treatments. A very small tube called catheter is placed into one or two of the blood vessels in the umbilical cord. Through that, infant gets IV fluids, nutrition, and medicines. Maintenance of nutrition. So usually 10% dextrose will be administered for preterm babies and respiratory syndrome, distress syndrome babies. And maintenance of IV fluids to the respiratory distress syndrome babies. Next is antibiotics. Antibiotics to prevent infection, usually ampicillin 200 mg per kg should be given in the IV 12th hourly, and also gentamicin 5 mg per kg IV 12th hourly can be given to the respiratory distress syndrome babies. This is the complication of respiratory distress syndrome babies. The first one is the intraventricular hemorrhage. Second, there is a chance for bronchopulmonary dysplasia, and also child will get pneumothorax, air collection in the lungs, intracranial hemorrhage, and child will get neurodevelopment impairment, and child will get retinopathy. So these are the complications will arise for the respiratory distress syndrome babies. Coming to the prevention, the best way of preventing RDS is after the delivery. So we have to, after the delivery, as soon as the delivery, we have to administer the surfactant to the babies. Otherwise, we have to postpone the delivery. See, if the deliveries cannot able to postpone, the best way of preventing the RDS is we have to give hormonal steroid hormone to the mother at least 24 hours before delivery. If delivery cannot be delayed, the mother may be given a steroid hormone similar to natural substance produced in the body, which crosses the barrier of placenta and helps the fetal lungs to produce surfactant. The steroid should be given at least 24 hours before the expected time of delivery. The next one is an alternative is to wait until the first symptoms of RDS appear and then immediately give surfactant. So as soon as the preterm baby wants, within 6 hours of delivery, surfactant should be administered. Prognosis. Prognosis with treatment is excellent. So, if you are giving proper treatment at the proper time, you can able to reduce the mortality rate at least 10%. With adequate ventilation or with adequate ventilation support alone, surfactant production eventually begins. And once production begins, ODS resolves within 4 or 5 days. So, in the meantime, severe hypoxemia can result in multiple organ failure and death. So, we have to detect the ODS as soon as the baby born. So, as soon as the preterm baby born, we have to administer the surfactant at the correct time. If you are administering the surfactant in correct time, you can able to reduce the mortality rate at least 10%, 10%. Thank you. Thank you for listening to my class.